Hello guys, I hope you're all doing great. Well, today I'm going to talk about coronary artery diseases. Coronary artery diseases involve stable angina, prinzmetal angina, and acute coronary syndromes. Acute coronary syndromes include unstable angina, NSTEMI, and STEMI. Now, these are the risk factors which will increase the risk of development of coronary artery diseases. And CKD and diabetes mellitus, they are equivalents of coronary artery diseases, which means that if a patient is suffering from CKD or diabetes mellitus or both, then you're going to treat such patient in the same way as you treat the patient of coronary artery disease, because these two conditions increase the risk of development of coronary artery disease exponentially. So you treat such patient the same way as you treat coronary artery disease patients. Okay, so if these risk factors are present, they will encourage the formation of atherosclerotic plaque. And if the atherosclerotic plaque is stable, that will cause this subtotal stable coronary occlusion. Stable coronary occlusion means that the atherosclerotic plaque has not ruptured yet. Okay, so that stable atherosclerotic plaque will cause more than 70% occlusion of lumen of coronary artery, and that will be sufficient to provide enough oxygen to the myocardium during rest. Okay, so the oxygen demand of myocardium during rest is being met by this stable coronary artery occlusion. But if such patients have some kind of emotional stress, or if such patients go through some kind of activity like, walking or running, that will elicit the chest pain and EKG changes as well. So what will happen in case of stable angina? That there will be subendocardial infarction during exertion, which means that chest pain will occur and EKG changes will occur during exertion only, and those symptoms and those EKG changes will return to normal when the patient goes to rest. Okay, so if the subtotal unstable coronary occlusion is there, an unstable coronary artery occlusion means that if this atherosclerotic plaque is ruptured, then it will cause even worse occlusion, and this unstable or ruptured atherosclerotic plaque will result in eliciting the symptoms even during rest. So if the plaque is unstable, that will cause subtotal unstable coronary artery occlusion, and that will cause subendothelial infarction during rest, and EKG changes will happen during rest as well. So it can happen either in unstable angina or in NSTEMI. And if this unstable atherosclerotic plaque or ruptured plaque causes complete or total coronary artery occlusion, then this will cause transmural infarction during rest, and that will cause ST elevation, and that is in case of NSTEMI. But there is a condition called prinzmetal angina, in which there will be complete occlusion due to vasospasm, and that will also cause STEMI, but cardiac enzymes will be normal in that case. So if there is chest pain with exertion, and also EKG changes occur only during exertion, and all these symptoms return to normal with rest, then we are dealing with stable angina. If there is chest pain during rest and troponin level is normal and the pain settles with sublingual anti-G or nitroglycerin, then we are dealing with unstable angina. If the resting pain persists for more than 30 minutes and troponin level is elevated and there are ST depression and T-wave inversion on EKG, we are dealing with angstemi. If there is resting chest pain and the patient is smoker and the chest pain settles only with calcium channel blockers or sublingual nitroglycerin, and there is elevation, ST elevation on the EKG, but the troponin level is normal, we are dealing with Prinzmetal angina. And in Prinzmetal angina, we need to counsel and convince the patient to give up smoking, because smoking is extremely strong risk factor for Prinzmetal angina. And beta blockers are contraindicated in Prinzmetal angina because beta blockers like propranolol, it will cause unopposed alpha receptor mediated vasospasm, so that will worsen the Prinzmetal angina. And if there is chest pain during rest and that chest pain persists for more than 30 minutes and there is ST elevation on EKG and troponin level is elevated as well, we are dealing with STEMI. Now, how are we going to deal with the coronary artery disease patients? So if the patient comes with the complaint of chest pain and the patient is sitting in front of you, and at that time if the patient is having no symptoms, then what you are going to do, that you will ask that patient to go through the cardiac stress test. If the patient is stable, hemodynamically stable, or if the patient is not having any kind of joint disease like arthritis, then you will ask that patient to go through the treadmill stress test. And if during that treadmill stress test the chest pain is elicited and EKG changes occur, then we are dealing with stable angina, okay? And if the patient is not suitable to go through the treadmill stress test, for example, if the patient is not stable, or if the patient is having some kind of joint disease, for example, arthritis, then you will ask that patient to go through the pharmacologic stress test. So in that case, you can give the patient you can give the patient regadenoson or adenosine or dipyrimidol. Most of the time you are giving regadenoson. So that will elicit the chest pain and EKG changes. And on nuclear imaging, you will see the constriction, okay, constriction of the coronary artery. And you can also give dobutamine as well. Dobutamine will also cause elicit the same chest pain and EKG changes. So if cardiac stress test is positive, then you can go for angiography, okay, because angiography will let you know the exact location of obstruction or occlusion, and then you can perform the angioplasty, okay. Now if the patient is sitting in front of you and he says that he's still having the chest pain, and you run the EKG, and on EKG there is ST depression, and if there is ST depression and T-wave inversion on EKG, then you will ask the patient to allow you for troponin, serum troponin, okay, And if serum troponin is normal, then obviously you are dealing with unstable angina. If serum troponin is high, you are dealing with NSTEMI. So in NSTEMI, obviously you are not in a hurry. What you're going to do that, obviously you will perform the angioplasty, but you can perform it even within 24 hours. It doesn't require emergency angioplasty, okay? And if, for example, the patient is going through chest pain and you do the EKG and it shows ST elevation, and then you also run the troponin test and that the serum troponin is elevated, then obviously you are dealing with STEMI. Now you are in a hurry, okay? You have to be very quick in performing the angioplasty. So you have to prepare the cath lab, and you have to take the patient to the cath lab in order to perform the angioplasty, okay? And if all these tests are not positive for coronary artery disease, then you need to look for these field differential diagnoses, which are pulmonary embolism, aortic dissection, and tension pneumothorax. So for pulmonary embolism and aortic dissection, you can run CT, and if the CT is positive for them, then obviously you are gonna treat these two conditions. And you can perform chest X-ray for tension pneumothorax, and if these conditions are present, then obviously you will treat these conditions. So the point I'm trying to make that whenever there is a patient who is having symptoms of coronary artery diseases, or especially who's having the chest pain, then you should also be looking for these field situations also, okay? Now, well, this is the kind of a mnemonic for the treatment of coronary artery disease, which means that if the patient of coronary artery disease is there, you will follow this medication protocol. So you will give obviously a nitroglycerin, you will give oxygen, and you will give metoprolol unless there is contraindication, for example bradycardia or acute MI. And you will give morphine if there is pain that is resistant to nitroglycerin. And you will give anticoagulants like aspirin. Aspirin is, you're going to give aspirin for lifetime in patients of coronary artery disease. And you can give unfractionated heparin. And diuretics can be given as well, statins forever, lifetime, for lifetime, okay? And then you can perform the stent placement procedure as well. And after stent placement, you have to give that patient dual antiplatelet therapy. Otherwise, stent restenosis or thrombosis can happen, okay? And obviously, drug-eluted stent is preferred because that prevents restenosis. So next is about complications of MI. If, for example, the MI is not treated timely, then these complications can happen, okay? So first 4 days are extremely dangerous because arrhythmias can happen, especially during first 4 days, and these arrhythmias can cause sudden cardiac death. And arrhythmias, especially ventricular tachycardia or ventricular arrhythmias, they are most common cause of death within first 24 hours after MI. And obviously you have to do the serial EKGs, okay, to check whether or not the patient is going through arrhythmias or not, okay? And in 3 to 10 days, there is increased risk of free valve rupture of left ventricle. So for that, you have to do the transthoracic echocardiography, and tamponade can happen during 3 to 10 days, and obviously you will do EKG for that, and you will do transthoracic echocardiography, and there will be back triad in case of tamponade, and that back triad is that there will be hypertension, distant heart sounds, and the third one is the jugular venous distension. Okay, you will give intravenous fluid because the patient is hypertensive and hemodynamically unstable, so you have to give the fluid in order to stabilize that patient, and then you will perform the pericardiocentesis, and you will also create a pericardial window. And if there is papillary muscle rupture, that can cause obviously severe mitral regurgitation, that can cause cardiogenic shock. So you will do the transthoracic echocardiography in order to look for the papillary muscle rupture. And valve repair or replacement is the management for papillary muscle rupture. VSD can also happen due to the rupture of interventricular septum. So obviously you will do the transthoracic echocardiography, and obviously in papillary muscle rupture, you will hear the murmur, the holosystolic murmur at apex. But in case of VSD, you will hear murmur, obviously holosystolic murmur, at left sternal border or parasternal border. And obviously the therapy is VSD closure repair. Weeks later, these complications can happen. Bressler's syndrome, which is the formation of autoantibodies against the pericardium. So there will be pericardial rub. On auscultation, there will be chest pain that will get worse with lying down, and that will be relieved with sitting up or leaning forward. The treatment is colchicine, NSAID, and steroids like ibuprofen. Aneurysm can happen after weeks as well. So persistent ST elevation will, should increase your suspect for aneurysm. Obviously, you're gonna run the transthoracic echocardiography that will show the thin dyskinetic left ventricular wall. It can cause secondary mitral regurgitation. There is increased risk of thrombus formation. Obviously, it will also increase the risk of embolism. So cerebrovascular accident is a risk for in case of aneurysm, left ventricular aneurysm. And obviously this aneurysm can result in left ventricular thromboembolism. Okay, so you are going to give anticoagulants, especially apixaban, in this condition. Okay, and in order to prevent these complications to happen, you have to perform early reperfusion therapy. So in case of STEMI, you have to perform the percutaneous coronary intervention, like this stent placement or cabbage within 90 minutes, or at least within 3 hours. And in case of STEMI, you have to, or unstable angina, you have to perform the reperfusion therapy within 24 hours. Okay, and in case of stable angina, although the medications are enough, but you still can perform the percutaneous coronary interventions. But even if you don't perform this intervention in case of stable angina, the patient is still safe. Okay, now this is the very typical case for stable angina, that the patient will be elderly and he will be having chest pain while exertion or emotional stress. The pain will be relieved with rest. So EKG will be normal, biomarkers will be normal when you will perform the stress test, it will cause EKG changes and it will elicit the chest pain. So you will perform the cardiac catheterization, and on catheterization you will find the blockage of either right coronary artery or any left coronary artery or any of the branches of left coronary artery. Okay, and then you can treat that patient with medications like anti-G, and you will put that patient on aspirin and statins forever, and you will obviously be giving that patient beta blockers because they will prevent the recurrence, and they will also beta blockers will also prevent the remodeling. Okay, so you can stent can be placed in case of stable angina as well, right? Now, the typical case for unstable angina or anstomy. So the patient will be presented to ER with chest pain. In case of anstomy, biomarkers will be elevated. In case of unstable angina, biomarkers will be normal. So there will be absence of ST elevations. So you will give that patient the medical therapy, aspirin, metoprolol, and heparin drip, and you will admit that patient to the cardiac floor. And on second day, you will perform the angiography, and that will show the 90%, for example, blockade of the, for example, left anterior descending artery, and obviously you will perform the percutaneous intervention. Okay, so you will place the stents, and you will obviously give dual antiplatelet therapy after placing stent. That will prevent thrombosis of stent. Okay, so dual antiplatelet therapy, which is aspirin and clopidogrel, okay, which is PY1/2 receptor and antagonist. Okay, so long-term therapy in case of unstable angina or anstomy is aspirin and statin. You can give beta blocker as well, but beta blocker is given mainly in case of STEMI, because beta blockers prevent the remodeling, which means that it will prevent the the dilated cardiomyopathy or the hypertrophic cardiomyopathy, because it prevents the remodeling of heart. Okay, and this is a typical case for a STEMI, which is the patient will arrive to the ER with chest pain. You will do the EKG, and EKG shows ST elevations, so you need to be in a hurry. You prepare cath lab, and you give the patient aspirin, metoprolol, nitro drip. You give heparin bolus, and then you immediately take patient to the cath lab. You perform the cath procedure, which is the percutaneous intervention, which is stent placement through femoral or radial artery approach, and you have to perform within 90 minutes. Okay, because that prevents the complications. Now you have to give long-term beta blockers in case of STEMI, because they will prevent the remodeling. And remodeling happens due to number of hormones, norepinephrine, epinephrine, angiotensin, and also the aldosterone. They will encourage cardiac remodeling, which means that they can cause eccentric or concentric hypertrophy, which is very, very pathologic, and it will shorten the patient's life. Okay, so by giving beta blockers in, for example, ACE inhibitors or aldosterone receptor inhibitors, or the ARBs, you will prevent the cardiac remodeling. Okay, so this is all about coronary artery diseases. If you find it helpful, share it with your friends. and subscribe my channel. Thank you for watching this video, and thank you. Bye bye.